So this time I'll go ahead and introduce our topic and our speakers. We're talking about detection of chronic kidney disease of unknown etiology in Florida. And this is a research project through the Southeastern Coastal Center. And our two speakers are Dr. Norman L. Beatty and Dr. John Diaz. And just a quick note about them, and then I'll turn it over to them. So Dr. John Diaz is an associate professor and extension specialist in the Department of Agricultural Education and Communication at the University of Florida. And then the first presenter you will hear from today is Dr. Norman L. Beatty, who is an assistant professor of medicine at the University of Florida College of Medicine, Department of Medicine, Division of Infectious Diseases and Global Medicine. So we're very thrilled to have both of them, and I want to thank all of our attendees for joining today as well. So at this time, I'm going to turn it over to our speakers.
Good morning, everybody. Well, good afternoon. Sorry, let me share my screen here. And we'll get started. Okay. Well, today we're going to talk about chronic kidney disease of unknown etiology. And what do we know about this disease? Me and Dr. Diaz and our team are really going to dive into this here in the state of Florida. And it is something that's we'd like to bring awareness to here in our state and likely in other regions of the United States. So what is CKDu? CKDu is chronic kidney disease of unknown etiology. It is an emerging public health concern, and the reason why we call it CKDu is because an individual may have or is developing chronic kidney disease, but we don't have a clear explanation why. There's a whole handful of chronic conditions that are associated with the development of chronic kidney disease itself. But at this time, there's a subset of people who develop chronic kidney disease, but we have no idea why it is happening. And why is this important to the agricultural community? Well, it is been shown in multiple regions of the world, and that CKDu is associated with agricultural health and farm working. And we're trying to figure this out. We're trying to figure out why this is a concern for agricultural workforce. One thing about CKDu is folks are asymptomatic for many years. We don't have a great way of screening people for chronic kidney disease, and they usually present pretty late in the stage of chronic kidney disease and rather young. And most folks are kind of in middle ages and between 40s and 50s, if not a little younger, but predominantly affecting males. So this is just a figure showing the continuum of care for people living with chronic kidney disease. You know, even infants and children, there's certain conditions that cause chronic kidney disease, and teenagers and young adults and adulthood, even going through middle ages and into elderly. There's different things to consider when caring for somebody with chronic kidney disease. And this is especially important for people who are dealing with CKDu. Most of these individuals, again, are in our workforce. They're working in agricultural industries. They are a pivotal aspect to their family's income, and CKDu can have an impact on communities. And this is one thing that we need to consider here is, why is this disease so neglected right now, and how can we learn more about it? And this pyramid shows just what we see with individuals who are developing chronic kidney disease as it progresses. As mentioned, a lot of people who eventually present to healthcare where they are discovered to have CKDu are in the kind of later stages, stage 4 and stage 5. This is a time when people are actually preparing for what's the next step for chronic or for kidney replacement therapy, whether it's going to be dialysis or even a kidney transplant. And as you would imagine, folks who are developing CKDu working in agricultural sectors may not have as much resources as other people in other industries. So something that we really need to keep in mind is who is impacted by CKDu and what's it look like for an individual once they develop this condition. It's pretty daunting. And so we really are trying to sort this out here in the state of Florida because we have a lot of agriculture. And so at this time, what do we know in around the globe about CKDu? We know that there have been some studies looking at different populations, most of them within the tropics, showing the development of chronic kidney disease that's unexplained by other comorbidities. And there's some common threads or patterns within these regions. We see it once being called Mesoamerican nephropathy due to being discovered in certain areas of Guatemala and southern Mexico, Nicaragua. But we also are seeing this in other regions, like in Egypt or certain areas of southern India. Sri Lanka is a place that is really diving into research on CKD. And so, this is the condition that is emerging in the global health scene. And do we have this here in Florida? I don't know. We'll figure it out. Africa is another continent where research is really starting to dive into this topic. These are countries right now where they have done prevalence studies looking at CKDu in their populations. And as you would imagine, the more you look, the more you find. And so right now, these studies are ongoing to investigate the development of this condition, especially, again, in our agricultural workforce, because these individuals are essential to our communities, essential to food production, and so we really can't take a blind eye to this. And so what are the clinical characteristics of CKDu? What are things that have been implemented in the development of this condition? Well, one, agricultural communities has been very much well seen in the literature for developing chronic kidney disease of unknown etiology. And other things, that we're hypothesizing the risk factors being, one, heat stress or heat related illnesses that we're seeing is continuous acute kidney injury leading to the development of chronic kidney disease. I think that's likely, but there's other things that are happening, and it's probably multifactorial, meaning multiple factors all at once contributing to the development of chronic kidney disease earlier in life. And so this could include groundwater contamination with certain substances or the use of certain herbal supplements in certain communities. Even having genetic predisposition has been described, or heavy metals that are found in the soil that are taken up by plants. We're also seeing possibly certain pesticides associated with CKDu, and the list goes on and on. But for right now, we really need to figure out what is happening here in our state and how is this relevant. And so I like this slide here because it really talks about heat stress and kind of the mechanisms at which one could develop ongoing acute kidney injury, and also ties in fructose containing drinks. These two factors together have been shown to lead to acute kidney injury. And as you would imagine, an individual working 5 to 7 days a week, and then the summer Florida heat, and who may not be as well hydrated, and who's consuming fructose containing drinks day in and day out, eventually they're going to be developing continuous AKI or acute kidney injuries that could lead to chronic kidney disease. So really, the mechanisms of CKDu are obviously not well established right now, but and eventually the hope is that we will be able to not call it CKDu anymore. But right now the mechanisms are a bit unclear, and we have researchers right here in our center who are looking at this. But something that when working with farm working communities, it's really important that we discuss the heat stress dehydration, and water consumption and avoidance of fructose-containing drinks. It's likely contributing to this condition. So other proposed mechanisms that have been cited in the literature and have been found in certain communities. So one would be groundwater. Certain groundwater contaminants, especially in regions where they have kind of shallow well systems. At least in like Sri Lanka, for example, they had a 5-fold increase in developing CKDu. Certain agrochemical exposures, have been implemented. There's mixed data on this in the studies that have looked at different regions of the world, but there's likely some correlation with glyphosate containing products. This has been noted multiple times in studies. What are the metabolites, or what are the actual molecular mechanisms of this? Really, it's unclear right now, but is there an association? It's probable. Heavy metals in the environment that have been there from previous industry, that may be there naturally. Cadmium is one that's been implemented. It's been seen in Japan to cause CKDu, but other heavy metals that are kind of leaching into the soil and the water have been seen in patients living with chronic kidney disease of unknown etiology. And then genetic predisposition. So, there's certain genetic traits that have been implemented and looked at from genome-wide association studies to kind of look at, well, is there kind of a phenotype within certain human beings that would give them this predisposition? And again, Sri Lanka and India really dove into this. And I've seen some genetic correlations with this, but it's really important that we recognize there's much more to the story here than the traditional comorbidities we see with CKD. So here's a study here looking at the prevalence of CKDu in 3 rural farming communities in Sri Lanka. Sri Lanka has done really a fantastic job at looking at this and CKDu. They have basically mapped out the prevalence within their country. And this is the most recent study just looking at 3 farming communities that were either paddy farmers, sugarcane, or vegetable farmers. And then they did an age-matched control of non-farmers. And about 1,500 participants were in this study. And one of the important inclusion criteria is that they had to continuously be living in one of those 3 farming communities for 10 years and actively involved in farming for 10 years. And they could not have been already diagnosed with a kidney disease. And so they followed these individuals over a 10-year period. And they took blood and urine samples, and then they did calculations to look at renal function. And so as you can see here on the map on the right, you can see the prevalence of CKD and CKDu on the island of Sri Lanka in that country. And 2 of those regions of the farming communities were within that scope of CKDu. And then one of them was kind of an unknown whether or not it was present. So what did they find here? I think it's really important to show that one, people were living with CKD without having a diagnosis yet, but 18% within these 2 regions here, they were the paddy farmers and those in sugarcane farming. And then also we see in the vegetable farmers, VF, they also had about 13% of that group had CKD. What I think is really the most interesting is among these individuals who had CKD, they actually 79% or 73% had CKDu within that group. And that was among the paddy farmers. Those who were in sugarcane farming, 69% were CKDu. And then the vegetable farming was 50% was CKDu. So among the ones who had CKD, they were able to attribute it to nothing. They didn't understand why they had it, but it was rather prevalent among those they discovered to have CKD. So this was among a group who previously did not know whether or not they had CKD, and through these screening protocols were able to find chronic kidney disease, as well as a large majority with CKDu. And so here's another, just a graph or depiction of the odds ratio of the different activities or possibly different risk factors. As you would imagine, with CKD, the odds ratio for the individuals that had hypertension and diabetes was rather high. That makes sense. You know, diabetes and hypertension are really associated with development of CKD. But as we can see in the group that had CKDu, you know, there were other factors that were important here to recognize. Well, one of them being sugarcane farming. The odds ratio was 3.4, which is rather strong association between those with CKDu and sugarcane farming. Another one was chewing betel, which is a hallucinogenic leaf that folks in the southeast part of Asia in the Indian Ocean will consume while they're working. This was also associated with CKDu, as well as in this study, agrochemical exposure through their surveying had an odds ratio of 3.1. So again, we're starting to see there's some patterns here, especially in Sri Lanka. Here's two just graphs, or there's one graph and an image here. The one on the left is just showing again the prevalence of CKD, where you can see in yellow and orange and red. And then underlying that is the groundwater fluoride concentrations that have been mapped on the island. And you can see a pretty clear delineation in the amount of fluoride present in the groundwater and people that they know of having CKD. So, you know, this may be a multifactorial condition, but, you know, it centers on the environment and centers on people exposed continuously, likely to toxins and other elements that are just not good for the kidneys. Kidneys just filter things out of our bloodstream. And so continuous exposure to certain things are likely leading to this, especially like arsenic. For example, certain regions within Sri Lanka, they've found arsenic within the water system, within the soil. And this was from 2013, but it showed that people with arsenic distribution in their urine, you know, as they had higher concentrations, again, they had CKD develop on the blue bars there, and as their diagnosis was CKDu. But, you know, are we doing enough in certain parts of the world where we have contamination in our soil and our environment to look for chronic kidney disease, and what is the etiology? There's just a lot to do. So this is a fascinating study. I think it's really an important study. It's recently published this year, and scientists did a great job at looking at something likely relevant to us here in Florida, looking at sugarcane ash as it pertains to chronic kidney disease in rats. And so this is a mouse model that was developed. This group, largely from University of Colorado, they actually collected sugarcane ash that was burned in Nicaragua, brought it back into the laboratory, and they developed a method for intranasal administration of this sugarcane ash to two groups, one of them being, you know, the experimental group, the other being a control, which they were not exposed to the ash. They administer the ash once per day for 5 days per week for 13 weeks. And they sacrificed half the animals at 13 weeks, and then they let the other half survive for another 11 weeks, but they did not give them any intranasal ash at that time for a total of 24 weeks. And at the end of the study, they did blood, urine, kidney, liver, and spleen biospecimen collection on all the animals. So on the top right, you can see here on this figure, this is pretty striking here. So in the control group, we look at 13 weeks. We can, you know, that these are just pictures, histological pictures of tubules and the development of collagenase 3 or collagen 3, which is a marker for fibrosis. And B and D, in comparison to A and C, you can see that there's much more collagen 3 being found within the interstitium of the kidneys and within the tubules, just showing the presence of fibrosis there. And which is really just really striking to see histologically that now we have evidence that this is leading to kidney fibrosis and chronic kidney disease. So as you can see on the figure below, segmental glomerular sclerosis, there's looking at these H&E stains here. Again, we got the control groups in A and D, looking at 13 and 24 weeks. Those glomerular apparatus that looks all healthy. You can just see the cells are just present in the normal fashion. But if you look at B and E, that those figures there are the rats exposed to the ash, and there was much more glomerular sclerosis present, kind of that deep pink or reddish thickening that you can see between the cells is evidence that glomerular sclerosis is present. And this is an experimental model showing that the exposure to intranasal ash, which has a lot of silica in it, led to chronic kidney disease in these rats. And so they, just looking at the silica nanoparticles that were present, they're much different in their shape and size compared to the crystalline silica that we find in the environment. When it's in the ash form, it contains a lot of carbon. It contains other toxins that are found in the environment and with the burning process. And they found the silica nanoparticles throughout the body of the rats themselves, especially in the kidneys. And as you can see in figure A, those are the kidneys there. There was much more found in the kidneys at 13 to 24 weeks, but it was still present at 24 weeks. And interestingly, in the spleen, it was actually accumulating and persisting over time. So, something that we see in sugarcane harvesting or agriculture is after, at the end of the harvest, the fields are burned. And this is something that may be a risk factor for developing CKDu. And here's a model that may be able to show this. And just looking at this table here, looking at the rats themselves and their kidney function. At 13 weeks, it's pretty clear based off of the markers that they were looking at that within the ASH group, we just had significant presence of inflammatory markers, the deposition of collagen 3 and 4 within these kidneys histologically. And, one thing that I think is interesting from a clinical standpoint, being a clinician myself, this is histological evidence, but from a biomarker standpoint, the kidneys really didn't show much difference in some of the markers that we use, such as serum creatinine and BUN. So the kidney function itself was looking about the same, but histologically, those exposures were leading to the evidence that these rats would likely be developing the sequelae of chronic kidney disease because of the fibrosis and the interstitial thickening that we see in those conditions. So, these repeated exposures over time are going to likely lead to development of the renal dysfunction. And so here's another study. I think this is an interesting study from France. And they looked at a cohort of individuals, 230 people who were who had no diagnosis on their chronic kidney disease, and they looked at genetics. They looked at whole exome sequencing from peripheral blood, and they used a whole panel of markers for known genetic predisposition or genetic conditions that would be associated with chronic kidney disease. And yes, this methodology did lead to, as you can see here, 32%, where they were able to show, okay, this is likely why these people are developing chronic kidney disease. But what I think is so fascinating is that in this group, it was still unsolved. Greater than, 2/3 of these individuals. And there's just so much more that we need to learn about people who are living with chronic kidney disease of unknown etiology. Why is this happening? And a large segment of these individuals are from Europe, and this study did not really look at agricultural communities. It was really just showing that this methodology of genetic sequencing could help in the diagnosis. And it likely is a tool that could be used. But for me, I'm looking at this like, wow, there's still, even with advanced molecular work, we still don't understand 2/3 of the reason why people are developing this condition. And there's just a lot of research that we need to do because chronic kidney disease is pretty tough for patients and families. So here in the state of Florida, we have rather robust agricultural workforce, multiple industries that are found throughout the state of Florida, as most of you know on this call. And, are we dealing with this in our communities? Is there a certain agricultural industry more at risk for the development of CKDu? Is it even here? And no one's ever looked at this. And so that's one of our intentions here for our project. How are we going to do this? And the big question is, are farm workers living with CKDu? We have a plan to analyze data that exists so that we can come up with a prevalence of CKDu within our state and looking at large data sets. And by utilizing a multidisciplinary team, which Dr. Diaz will talk about, and our outreach, we're hopeful to bring awareness to this here in the state of Florida. So what is the prevalence of CKDu in Florida? That is unknown right now. There has not been a study to really look at this in the population. As many of you know, we have what's been estimated as 9.7 million acres of agricultural land and 47,000 farms that are registered within our state. And so, the big question is, are Florida farm workers at risk for CKDu? And so there is a study out there that does point us in the right direction. This study was published in 2018. It was conducted in Pearson, Florida, and it took place from August 2015 until June of 2016. And I think it's a great study, which we can build upon. And looking at what they were able to accomplish, they looked at farm workers in this area from 18 to 54. And they had to be working in agriculture for at least 1 month. And they excluded folks who were living with type 1 diabetes or who were pregnant. And among the 192 agricultural workers, they followed these individuals for 3 consecutive work days. And prior to following them, they did a baseline clinical assessment and they did a survey on that day and a non-work day. And then they provided a sterile cup for the individuals to go home with. And when they awoke that day, they took their morning void and they brought it to their shift. And that was their pre-shift urine collection. And then after their shift, they took another urine sample. And they did the same for blood and blood samples as well, pre and post shift. The majority of the participants were working in the fernery industry, but some were also working in the nursery and field crop industry. They collected social demographic information, lifestyle data, and then they calculated heat index on these days, which I think is really an important part of what we're doing right now. And so looking at the demographics and characteristics of these individuals, as you can see, most of them the mean was 38 years old. Some were a little bit younger, some were a little bit older. The majority were actually female, and I think that's another trend that we're seeing in agriculture, more female workers. The majority were originally from Mexico, some from Guatemala and Haiti, and a low majority or a low amount of people were from the United States. And then years of education, as you can see, 6.5 years. And so what do they find? So one, as you would imagine, among this group, they did find a fair amount of hypertension or high blood pressure screening these individuals, which would put them at risk for kidney disease in general. Some did smoke, about 14%, but most of them were not smokers. And, as you can see, though, at least 33% of them had normal blood pressures. They had no concerns for hypertension. What I think is really important and what I do see in the field is that, there's access to clean water, or at least drinking water while working. I know that's not the case everywhere, but they had access to water. But one important factor for CKDu, I think, is what else is being consumed while working and possibly while dehydrated. And looking at kind of what was the surveys that were given here, sports drinks, they didn't really talk about what those sport drinks were. Did they contain a lot of sugar? I think that's important to look at. But other things that folks are consuming, energy drinks, they can have a lot of different molecules in them that could irritate the kidneys. So, there was a whole plethora of things that farm workers are consuming when they're working. So what did they find here? And looking at how they assess acute kidney injury, they looked at specific gravity. And so for anything greater than 1.020, you would be considered to have kind of dehydration or concentrated urine. And even at pre-shift, you can see that 53% of this group had concentrated urine, and after their shift, 81% had even higher than they did before their shift at 81%. What I even think is more striking is how concentrated. This is an extreme amount of concentrated urine, and 13% of those who started off with only 3% started off with 1.03, and then an additional 10% ended up with really extreme amount of dehydration shown in their urine. And but again, the changes in glomerular filtration and serum creatinine, weren't striking. But I think it's important to note that this is a daily process for our farm workers at times, and it's the continuous, repeated insult to the kidneys, which may be subtle, which I believe is likely leading to this. They did show that about 31% had acute kidney injury at stage 1 during these 3 days. There's not a small number. And so this graph, I think, really tells the whole picture here. Looking at the specific gravity on those 3 work days following these individuals, the mean trend for each day for all the workers was an increase throughout their shift. And so, hydration, super important. And, how can we educate, and how can we help our farm workers and agricultural workers understand the importance of drinking water? I think water is what we need to be helping them understand, and clean water, not just well water, but that's another discussion here. So we go back to this image here, and we think about repeated acute kidney injury, and we have examples of this here in Florida. And, is this leading to CKD and CKDu? I think it's possible. What are we doing here? What is it going to be our project? How are we going to look at this in Florida? Well, one, we have a great partnership with One Florida, which has data available at all these locations throughout the state. Hundreds of thousands charts that we will be analyzing using a computable phenotype to look for CKDu, which we have designed to exclude all the known conditions that are known that to be associated with CKD. But as you can see, there's many gaps here, and and the institutions that we're collaborating with already. And so we have built a network, and our network is growing within some of these agricultural regions so that we can refine this data. And so we can help align it with agricultural communities. So some of these sites, as you can see here on the right, we're already working with or planning to work with. And this will help clean up the data, make it more robust to help us understand whether or not this is associated with agricultural communities. So, for example, we have partnered with Suncoast Community Health Centers. They're in Polk and Hillsborough County. They're a fantastic, fairly qualified health center who have at least 4 locations where the primary patient population work in agricultural sectors in that area. And they have at least 60,000 unique patients in their network. So we're really excited to partner with them, as well as Community Health of South Florida, CHI. They have 13 locations in Miami-Dade, Monroe counties. And I was just down in Homestead. There's quite a robust agricultural scene, as many of you know. And they have 5 locations, and at least that are really close or cater to agricultural workers, as well as 2 that were nearly 100% of that population and their families are associated with farm working, and they have over 80,000 patients in their system. So this computable phenotype, what is it doing? Well, it's going to be through methods to analyze charts, looking at those with CKD. We're able to look at the different stages of CKD, able to understand whether they have end-stage renal disease, on dialysis, and even receive a kidney transplant. And something that we're going to be able to do is look at whether they reside in rural, suburban, or urban centers. And our goal is to be able to hopefully see differences with CKD and CKDu within our state, and hopefully be able to show whether or not there's proximity to some of these major agricultural communities within our state. And we've been able to design an exclusion criteria to remove patients from this phenotype who may have already an existing diagnosis of why they have chronic kidney disease, as well as excluding other comorbidities that we know are associated with the development of chronic kidney disease. And most importantly, hypertension, diabetes, polycystic kidney disease, other processes which we would explain why someone would develop this. We have already done a little bit of data here, a little preliminary data. So we've looked at a fair amount of charts from UF Health from June of 2011 to October of 2023, and applying the commutable phenotype to 57,000 charts of people diagnosed with CKD. We've been able to show that in our system, we've have a prevalence of 8.96%. And this is preliminary data. It's not published yet, and we're still refining some of this data. But I think this holds true to other studies that are looking at regions where CKDu is present. And I'm pretty excited to see that this is present here in our community, and look forward to bringing more awareness to this. So I'm going to turn the time over to John here. He's going to quickly talk about our team, our outreach efforts, and everything that we're doing for the study.
All right. Well, thank you, Norman. So on this slide, you can kind of see the team that we've built. And as you all know, public health is not a sole discipline-based paradigm. It really requires a multidisciplinary team. And so we're trying to bring that to this project. So we're not only looking at the biology and the chemistry, but also looking at the economics and the social processes that underpin these disparities that we're seeing within the agricultural workforce. Next slide. So some of the work that we've been doing in this space is initially conducting some outreach and educations to form some initial connections with these audiences to better understand what they're doing and how they're currently serving the agricultural community. We're using CKDu as one of the types of illnesses that are affecting the farm worker communities, but we're having more comprehensive and holistic conversations, not only with our partners on the ground, but the farm workers themselves. Next slide. So we've worked within our network and strengthened existing partnerships and looked for new partners to try to bring a coalition to farm worker health. And so Dr. Beatty has done a great job at outlining some of our newer partners, whether they be Suncoast Community or Community Health of South Florida, but working with these different partners that have different perspectives and linkages to the farm worker community to really understand the realities that exist within the farm workers. So we know that within various public health issues, the social disparities of health really need to be evaluated. And within this paradigm, the realities of the job of farm workers are one of those social disparities that we're trying to work with this set of coalitions and this set of partners to better understand. So through these linkages, we're connecting with the organizations and the farm workers to better understand those on-farm realities and the realities of their lived experience to better understand how to create different educational interventions that really wrap themselves around the holistic needs and issues that these farm workers and farm worker organizations are attempting to address. Next slide. So one of the modalities that we're working with our coalition of partners is with health fairs. We understand one of the biggest issues or one of the biggest social determinants that is affecting the agricultural community is access to health care. Their reality of the job of on the farm is 6 to 7 day work weeks. And so that really leaves very little time for them to come out and receive care for themselves or their family. So we've been providing health fairs either standalone or in collaboration with worker protected standard trainings through the EPA to do everything from health screenings, vaccinations, and helping them to schedule follow-up care with those local clinics. And so one of those examples is Suncoast. We partner with Suncoast, so they're with us helping to screen and provide vaccinations, but then are also there to schedule follow-up care with the farm workers to make sure that there is that continuity of care. We're not just diagnosing them with CKDu or diabetes or anemia. We're doing that, and then we're coupling them with a physician in their area to hopefully get them on a treatment plan. Through these efforts, we've begun to collect some of the knowledge and behaviors related to CKDu. So as Dr. Beatty articulated, hydration and hydration behaviors are one of the areas of focus, but just understanding what it looks like on the ground when they're in their workday of hydration and other factors that may be limited their ability to take care of themselves when it's, those hot summer months here in Florida. Next slide. And so those initial efforts of outreach and extension engagement are moving to more of a holistic effort, starting with a curriculum needs assessment. So we've been fortunate enough to be funded through BenSAS strategic initiatives to really look at this issue in a more systematic way. And so Dr. Beatty and I and the team that we've developed will be developing a farm worker advisory committee, which will then be transformed into a participatory action research team. So this is essentially putting farm workers at the head of the table and working with us in collaboration to identify how to conduct a needs assessment to really address the needs and issues that are existing within CKDu and the farm worker reality. So, understanding what the current condition is and related to heat-related illness, CKDu, and the other really risky factors that they're connected with on the job, and then use that to create a multi-level assessment to understand needs, issues, opportunities, threats, etc. at these various levels, and then work in collaboration with the farm workers and champions to develop a multi-level educational intervention. So it's not only targeting the farm workers and building their skills and abilities, but also, at the family level, how you can build resilience and capacity within that level. Then also looking at farm managers, farm organizations, and policy levels to see what opportunities for change exist to help to mitigate the exposure of these risk factors to the farm workers to hopefully help to address the source of the issue of CKDu and other heat-related illnesses. Next slide. So in this effort in developing this participatory action research team and the advisory committee, we think it would be a disservice to simply look at CKDu and heat-related illness. So we will capitalize and take advantage of the development of this structure and process to look at the breadth of public health issues and public health risks that farm workers are currently experiencing, and leveraging that group to do that. The participatory action research team will work to lead the collaborative development and implementation of a research agenda, essentially with the overarching vision of enhancing not only individual capacity, but also transforming the policy systems and environments that these farm workers have to live and work in, to hopefully transform the realities so that CKDu does not continue to be an issue. We get it at the root problem. So Dr. Beatty really explained, hey, the biological manifestations and data, and how do we help to track it on that side, but then also from a social standpoint, how do we understand the social underpinnings of these diseases and these illnesses, and how do we transform those social realities so that there isn't that continuous feeding of farm workers to these risk factors. We're transforming the realities of the job and hopefully stymieing the occurrence of CKDu and other illnesses and diseases that the farm workers are regularly dealing with. So that's our presentation. Obviously, if you guys have any questions after the fact, our contact information is here. But we would open the floor for any immediate questions or reactions based on our presentation today.
Well, thank you so much, Dr. Diaz and Dr. Beatty. Yeah, as Dr. Diaz said, if you have questions, once again, you can type those in the chat or use the Q&A. We'll keep that up and just type them in as you're thinking of them. And then we'll address them. So there is one question from Carolina. Good afternoon. Thank you for the amazing presentation. Regarding the ongoing study, I am curious if considering the locations of the Floridian CKD participants might also play a role in their water quality consumption, such as if they live near areas that get easily flooded, rivers that get the runoff from water filtration treatment centers.
Yes, wonderful, Carolina. Thank you so much. And we are interested in seeing if we can map that data once we go to the statewide level, and looking at what data exists for quality of water within these regions. And as you likely saw in some of these regions where CKDu the research has been ongoing for 10, 20 years, they are seeing the water level quality being associated with development of chronic kidney disease. And so we have intentions of doing that, and hopefully we'll be able to look at the data in a way that would help to show whether there is a correlation or not. The data may not be as robust as we'd like it to be for water quality, but we do have intentions of doing that. It's a great thing.
And so one of the players, or one of the collaborators on our team, is going to be focused on this aspect, essentially conducting geospatial analysis in relationship to health data to really understand some of these environmental risk factors that we need to consider in these different populations. So proximity to quality water will obviously be one of those, but it'll be a list of different factors based on the composite and the cross-section of factors that we find within our own work, but also the studies that have already been published.
So while we're, go ahead.
No, just any other questions?
So yeah, there is one from Jeannie. Will there be efforts to involve the growers in addressing the work conditions, and also regarding training and offering better access to drinking water, etc.?
Absolutely. So that would be part of the multi-level assessment. So we'll be talking to farm workers, but we'll also be talking to farm managers, farm owners, and others to really understand the realities at those different levels and what opportunities exist to address those issues at those various levels. So absolutely, we'll be talking to the growers themselves and having a conversation around what opportunities exist to increase access to better drinking water for farm workers.
And a segue off of that, John, one of the regions that we'll be primarily focused on for that work is in Waimama. And so, we really are going to try to develop kind of a model that could be useful in other regions of our state where we have large agricultural communities, and to show that kind of a model like this will be useful in awareness to chronic conditions like this, but also ways at which we can break those barriers, break through the stigma, and find ways to have linkage to care, things of that nature. So our hope is that yes, our work will be able to be transected over time and improve care in other regions of the state.
I'll ask one quick question, and then if others are thinking of them, once again, please type those in. But actually, I will hold mine because we have a couple others. So first off, Jeannie says, in our experience, the smaller growers are problematic as they have fewer resources, and we hear from workers that the incidence of not having access to bathrooms, sufficient clean drinking water, breaks, etc. Too often the larger growers are involved, but the smaller growers are overlooked. So
Absolutely.
Go ahead.
Absolutely. I mean, I see that in various contexts, but the smaller growers are typically, they, like you said, have fewer resources and just have fewer things in place to protect their farm workers. So, and that'll be a group that'll be integrated into that advisory participatory action research team so that the smallholder farmers and those realities are part of the conversation and how to address this. So we understand those larger commercial operations have more funding, more resources to help to implement some of these best practices. So, just understanding how to adapt our approach based on the type of farm, the modality of farming, etc.
Thanks, Andy, for your chat here too. Yeah, I do want to recognize the different cultural aspects here, as well as a large subset of our agricultural workers are Haitian descent. We do have a behavioral assessments survey that we're doing, and when we go into the community, and we'll be able to possibly see whether or not there is some cultural aspects to consumption of water while working, and I think that's a point well noted here, as well as even within different regions of those who are from Latin America. We may see some cultural differences within certain subsets from people who've immigrated from different regions of Latin America. Great points here, and I think there's a lot of work to be done here for this in our state, and hopefully over the next 1 to 2 years, we'll definitely be able to show that CKDu is here. It's affecting our agricultural workers, and maybe possibly make some associations within these communities to why this is happening. But great point.
No, and I just echo and agree with your comment, Andy. It's the perception that if they're not working, that they're worried that they'll get their job back. You see that again with Latinos, Latino immigrants, and migrants, and so just trying to figure out how to reshape that stigma and perception so that they feel the comfort level in being able to take water breaks. And this isn't only relegated to agriculture. We see it in the construction industry as well. Folks that are on a hot roof for hours feel fear in taking water breaks when they direly need it. So how do we reshape that perception and educate not only the farm workers and construction workers, but their managers on the need and ability to take water breaks without compromising the output of the work. So absolutely a cultural issue within industry as well. So.
All right. Well, it looks like that's all our questions, I believe. And so we're getting close to the top of the hour. So let me go ahead and share my screen. Really, I don't really have a whole lot to add, except I'll just say to Dr. Beatty and Dr. Diaz, thank you so much for sharing today. great presentation, and of course, great work in the center and great work in your own areas that you're doing. Glad that we could report on this, and then of course I'm sure you'll have more things to share in the future as we go. And I want to thank all of our participants for being in here as well, and for a couple of great comments there. Just a couple quick things. First off, as you're exiting, once again, that survey should automatically load in your internet browser, and you can fill that out. It takes about 3 to 5 minutes, gives us some good, helpful feedback. Once again, you can always go to sccahs.org to stay up to date with what we have going on with our webinars and everything else. And so there's my contact information. Once again, I will send out the recording of the webinar by the end of the week, and so you'll have that. Before we close, any last comments, Dr. Diaz or Dr. Beatty?
Thanks for everyone who came today. You know, a lot of the folks on this call we either work with or know, and for all your work we do here in ag health and in our communities. So I'm glad that we could share information about CKDu today, and feel free to just reach out if you'd like to chat more or collaborate. I'm really excited that we can be part of the center together. So appreciate everyone on the call.
Yep, just echo that, and just echo the opportunity to talk about the opportunity to serve this incredibly important part of our population that is frequently overlooked. So really appreciate the opportunity, and look forward to collaborating not only with Dr. Beatty but others on serving the needs of the farm worker community in Florida and beyond. So thank you so much.
Great. Well, thank you again. And at this time, we'll go ahead and close the webinar. Have a great rest of your day. Goodbye.